Hi, good afternoon, everyone. Thanks for joining us today. My name is Lori Smetanka, and I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. We're glad to have you with us this afternoon. Folks are coming into the Zoom room right now, so we're glad to have you here. Today, we're going to do the next installment of our webinar series, COVID-19 Advocating for Nursing Home Residents, sponsored by the National Consumer Voice for Quality Long-Term Care, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. As you know, we've been hosting these webinars over the last several months to do our best to keep you updated on the latest information, guidance, and actions at the state and federal levels related to COVID-19, to talk about the impact on residents of long-term care facilities, to share resources, and to offer recommendations for advocacy. Next slide, please, Libby. One of the biggest challenges since COVID has been the restrictions on visitation and the separation of residents from their families, which has been going on for more than 6 months now. And we know this has been exceptionally difficult for both sides. Guidance recently released, guidance released by states and CMS over the last couple of months have been inconsistent in what they say and how it's been applied. And that's been very frustrating for all of us that have been working on this issue and that have been individually affected by this issue. So a couple of weeks ago, about 2 weeks ago now, CMS, which is the federal agency that oversees nursing homes, issued new nursing home guidance. It goes much further in recognizing the importance of reuniting residents and their families than other guidance from them has gone. And so that's what we're going to be talking about today to update you on that. So next slide, please, Libby. So our speakers today are Robin Grant, Director of Public Policy and Advocacy at the Consumer Voice, Jocelyn Bogdan, Program and Policy Specialist also at the Consumer Voice, and Eric Carlson, Directing Attorney for Justice and Aging. A reminder that today's webinar is being recorded. The recording and slides will be emailed out to all participants next week and will also be posted on the Consumer Voice website. You'll also be able to find the recordings and slides from the previous webinars in the series on our website. And in just a minute, we'll be posting a link to today's slides in the chat box. All of your lines will be muted throughout the webinar. Please post your questions for the presenters in the Q&A box on your control panel and use the chat to make comments or discuss points among yourselves. As a reminder, please keep your discussions in the chat civil and respectful to each other. So with that, I'm going to turn it over to our first speaker for today, Robin Grant. Robin?
Thanks, Lori. So we're delighted to be able to do a webinar on the revised CMS visitation guidance because that means there have been revisions, and that is very good news. In a nutshell, because my job is to keep this very brief so that you can hear in depth from our two other speakers, but in a nutshell, the guidance states that visitation must be person-centered and support a resident's quality of life. So the guidance has evolved from basically prohibiting all visits except compassionate care visits to allowing a range of different types of visits and actually requiring some visits under some circumstances. So as you can see from the slide, if I had to sum it all up, I would describe the visitation guidance as yes, but. Yes, the guidance permits visitation, which is obviously critically important for residents, but there are a number of restrictions that are placed on this visitation, and a great deal is still left up to facility discretion. So to tell you more about the yes part and the but part, I'm going to turn things over to first Jocelyn and then Eric. So Jocelyn, take it away.
Thanks. So I'm going to talk about the things that the new CMS guidance allows and the things that it requires. And I want to be clear that there's a big distinction between those things. I think the first time a lot of us read over this guidance, we were thrilled because it allows a lot. Whereas before everything was shut down, Now things look like they were opening back up. But upon rereading, we realized there are a lot of caveats in that, and Eric's going to speak to some of that in a few minutes. There's still a tremendous amount of discretion for facilities. That said, the guidance does now allow many things. It allows outdoor visitation, it allows indoor visitation, it allows compassionate care, it allows ombudsman access, it allows communal activities and dining, and it allows the use of CMP funds to help facilitate this visitation. Next slide. It also requires some things. It requires visitation in certain circumstances. It requires visits under the Americans with Disabilities Act with exceptions to allow equal access to care. And it requires healthcare workers who aren't employed by the facility, but who provide direct care to residents to enter unless they have work exclusions related to COVID-19. Next slide. So there's no question that it looks like we're in a much better place than we were a few weeks ago. And I think we really are. When we talk about what the guidance allows, what we mean is the guidance is no longer prohibiting these things. Before, visitation was shut down and it was easy for a facility to say, nope, the CMS guidance says we can't do this, so we can't do it, full stop. Well, now that's not the case. That's not what the CMS guidance says anymore. It's allowing facilities to do a lot depending on circumstances. However, in most cases, it's not going as far as to say the facilities must do these things. Sometimes it actually does say that, and we'll talk about those in the required section. But for most categories of visitation, the guidance is giving facilities the option to now open up to these types of visits with some discretion on the part of the facility. Next slide. So outdoor visitation. So we know that this is something that was happening in a lot of places before the new guidance came out. It wasn't happening everywhere. Now the guidance basically says, go ahead, open up outdoor visitation, take a person-centered approach and adhere to infection prevention. It even goes as far as to say that outdoor visitation should be routine and that except for weather conditions, an individual's health status, or the facility's outbreak status, these visits should be happening. It says that this type of visitation is preferred over others because it poses a lower risk, it's outside, there's more airflow and space. And it says that whenever practicable, visits should be outside, that the facilities need to create space for these visits. And it says there should be a process for limiting the number and size of visits that happen at the same time, and that there should be reasonable limits on the number of visitors visiting any one resident at one time. The guidance actually states that the county positivity rate does not need to be considered for outdoor visitation. So even if your county has a high rate of COVID, over 10%, the facility can still allow outdoor visitation. Though the guidance does later note that the facility can consider this positivity rate. So the facility could say that the county rate is high, we're shutting down. But the guidance still does seem to be encouraging outdoor visitation, and I think this is a welcome change. It states that these visits should be facilitated routinely, and to me that's pretty strong language from CMS. Next slide. Indoor visitation. This is also allowed. CMS doesn't seem quite as excited about indoor visits, but the guidance certainly goes further than anything that came before it. It lays out guidelines for indoor visitation to occur and looks at what else the facility should consider. So for indoor visitation, there can't be any new onset COVID-19 cases for 14 days, and the facility can't be conducting outbreak testing. Now the wording here is really important. It specifically says no new onset, which would not include a situation where a facility brings a patient in that they know has COVID. Onset means occurring within the facility. So indoor visitation can happen if a patient with a known COVID case is brought into your facility. Again, it's not required, but this guidance seems to allow it. Visitors have to adhere to core principles of infection prevention. So if you're running around without a mask or not socially distancing, it's not going to happen. Everyone needs to be screened, etc. Facilities need to limit the number of visitors and consider scheduling, and they need to limit movement within the facility to allow indoor visitation. They also need to look at the county positivity rate. Unlike outdoor visitation, here this really matters. The county positivity rate must be low or medium for indoor visitation. If the county positivity rate is above 10%, then almost all indoor visitation has to shut down. Only compassionate care visits will be allowed. Also, it lets facilities consider other factors in addition to the county positivity rate. They can look at the positivity rates in neighboring counties. They can look at COVID-like illnesses. They can look at the amount of trips to the ER when determining if they think indoor visitation is safe. So if the conditions above are met, then indoor visitation can happen. One other important point is that this guidance does not distinguish essential caregivers. I know there are several states that have created this category, and it's somewhat of a heightened category where essential caregivers have more rights than other visitors. That does not exist in this guidance. CMS says that because all of this is person-centered, essential caregivers are just absorbed into all other visitors, so be aware of that. Next slide. Compassionate care. So just like previous guidance, compassionate care exists and it goes beyond end-of-life situations. That has always been the case despite how some facilities have interpreted it. What's great in the new guidance is that CMS gives additional examples of what they mean by that. It notes that facilities should work with residents and their representatives and families and caregivers and their ombudsman to determine who needs compassionate care, and it lists examples, but it doesn't limit it to these examples. It's super clear about that. So the examples include residents who need emotional support. It includes people who previously had help eating and drinking who are now physically declining, they're losing weight or dehydrated, residents who have stopped talking and interacting, who are experiencing emotional distress. These examples are much more comprehensive. And again, they're still just examples. A lot more families should be able to fit under compassionate care if their loved ones have declined emotionally or physically over the past 6 months. It's a much more comprehensive category now. And these visits are not just immediate family members. The visits can be from any individual who meets the resident's needs. So this can include clergy, spiritual advisors, or really anyone else who you can argue can help the resident with their decline. There's still a social distancing requirement, and this actually runs throughout visitation. But in compassionate care, if you follow the guidelines, there can be personal contact for a limited amount of time. And also these visits are allowed for residents who are on transmission-based precautions for COVID. And as we discussed earlier, they continue even when community transmission is high. Next slide. So Eric's going to get more into some of this, but I just want to flag a few things that we don't know about compassionate care from the guidance. We don't know what happens when there's a new onset of COVID in the facility. Now, maybe because the guidance specifically says that residents on transmission-based precautions can still have these visits, there's an argument that they should still continue. The guidance also doesn't address how long visits are, how frequent, or the duration, as in if someone stops declining and starts to rebound as the result of these visits, do they get to continue to maintain their new status? We don't know. Next slide. Ombudsman access. So as always, ombudsmen continue to have immediate access to any resident, but like before, it's not clear the access will always be in person. The guidance says that in-person access can be limited for infection control concerns and/or transmission of COVID-19. It then goes on to say, though, that it cannot be limited without a reasonable cause, but it doesn't define reasonable cause. The example that it gives says that if the ombudsman has signs or symptoms of COVID-19, they can't come in. Well, that's obvious. I mean, we all know that in that case, the ombudsman isn't going to be entering. And whenever the facility has no reasons to limit access due to infection control or transmission of COVID-19, it would seem that they have to let the ombudsman in. So ombudsman, you should have this guidance with you when you go into facilities, and you should require that the facility gives you a reasonable cause if they try to refuse you entry. Also, the guidance notes that nursing homes are required to allow the ombudsman to examine residents' medical, social, and administrative records, as they always have been. So the facility cannot try to deny access to these records because of COVID. Next slide. Communal activities and dining. So this is pretty much the same as before. Communal activities and dining are allowed for residents who aren't in isolation or have suspected or confirmed COVID-19. But facilities, it says, should consider additional limitations based on the status of COVID-19 infections in the facility. This is not particularly strong language. So the facilities have discretion here on whether or not they want to do this. That said, CMS does seem to be encouraging it because they go as far as to list examples like book clubs, crafts, movies, exercise, bingo, activities that would lend themselves to this. So that's a little bit hopeful. Next slide. CMP funds. So before, at the beginning of the pandemic, CMS allowed CMP funds for a new category for communicative devices. And now they're adding another category. CMS has approved CMP funds to facilitate visitation for tents and clear dividers. Each facility is limited to a maximum of $3,000 for these supplies. Next slide. Okay, so that was what was allowed. Now we're going to move on to what the guidance actually requires, the good part, so to speak. Next slide. Okay, so here's the good news. There's some required visitation. Facilities, and this is exactly what the guidance says, facilities cannot restrict visitation without a reasonable clinical or safety cause. This means that unless the facility has a clinical or safety reason that's reasonable, they have to facilitate visitation. This to me is huge. Now, the guidance lays out what some of these reasons are. They list several cases where the facility can still restrict visiting, including the county COVID positivity rate, the facility's COVID-19 status, the resident's COVID-19 status, visitor symptoms, lack of adherence to proper infection control practices, or other relevant factors related to the COVID-19 public health emergency. They do not say what these other relevant factors are, but they do give an example of when visitation is required, and it's a great example. They say, if a facility has no COVID-19 cases in the last 14 days, and its county positivity rate is low or medium, so under 10%, a nursing home must facilitate in-person visitation consistent with the regulations. Okay, so if there's no COVID for 14 days and the county positivity rate is low or medium, then the visitation is, according to this, required. And if they don't facilitate visitation, they will be subject to citation and enforcement actions. So, while it's not exactly clear what these other relevant factors are, we now know that in some circumstances, visitation has to happen. This is really strong language. A facility cannot just keep you out because they want to. In certain cases, you get to visit. Next slide. So who is this required visitation for? It's for all residents who are not on transmission-based precautions for COVID-19. Residents who are should only receive virtual and window visits and compassionate care visits. However, this is a restriction that is lifted as soon as those precautions are no longer required. So just because someone had COVID before, if they are recovered, they still have the same rights to visitation. Next slide. Visits under the ADA are required. So the facilities must comply with federal disability rights law. They give an example. If a resident needs assistance to effectively communicate and that assistance isn't available on site and effective communication can't be provided without such entry, then the facility must allow the individual to enter the nursing home to interpret or facilitate with some exceptions. Again, they use the word must. So what does this mean? If you have a relative in a nursing home who has severe dementia, who doesn't really know the staff that well, who can't communicate with the staff, and who as a result of this lack of communication isn't having her needs met, but you understand her and you can help her communicate her needs, then you can argue that the facility needs to let you come in. What does with some exceptions mean? Well, we know that the guidance states that the nursing home can impose legitimate safety measures, but beyond that, it's not clear. Next slide. This is our last category of required visitation, healthcare workers who provide direct care. So, healthcare workers who are not employees of the facility, but who provide direct care to residents are required to be let in. Hospice workers, EMS, dialysis technicians, lab technicians, radiology technicians, social workers, clergy, etc. And they say etc. as long as they do not have symptoms of COVID-19 after being screened. And EMS does not need to be screened because they have the right to come in an emergency. So, Now that we know what the guidance allows and requires, I'm going to turn it over to Eric to talk about where the guidance falls short.
Thanks, Jocelyn. And you move on to the next slide, Libby. What I wanted to do for a few minutes here is just to flag some things that may pop up as issues in going through the guidance, thinking about where potentially there may be some ambiguity, or even if there's no ambiguity, just anticipating where likely problems are, where you can imagine some disagreements between residents with the state or with particular facilities, and where there might be some pushback. So first, we'll look at this list of exceptions, and Jocelyn mentioned this earlier, with those exceptions which allow a facility to deny in-person visitation. And you can understand the relevance of these. You know, as always, when you have a catch-all at the end, it raises some questions. And I can hear the facilities argument, just to give them a little bit of credit here. And I'll talk about a couple minutes. I imagine some facilities at least are going to have this position, which is, well, this is putting people at risk, and by having this catch-all, it allows them to legally respond to some situations that may present an inordinate amount of risk from their perspective. But I think as we all know, exceptions can be cited legitimately, or sometimes they can be a screen to cover up inappropriate actions. And that's obviously the risk here. You're going to get into some discussion about what's relevant. Is it related to the public health emergency and all the rest? And we'll have to see how that plays out. But you can imagine some discussion about that particular factor, just because it does give facilities some wiggle room, which may be exercised legitimately in some cases, and may in some cases be exercised in such a way that feels inappropriate. Next slide, please. And also look at compassionate care visits. I think this discussion is relatively simple. The point that I want to make here is that when we look at compassionate care visits, I think the right way to read the guidance is to understand that compassionate care as separate from the limitations that the other kind of visitation may be subject to. And there's some reasons listed here. First of all, for example, the guide specifically says that it's allowed even if the resident has COVID-19. If you look at the guides, the compassionate care section is separate from the other discussion about the quote unquote required in-person visitation. And then the other is just the way this has been implemented and how this has progressed, that compassionate care, as we well know, has been allowed by CMS throughout this period. So even when other kind of visitation was verboten, it was specifically recognized that compassionate care was an exception. It was a particular exception designed to respond to important individual circumstances. And I think the genesis and the continued use of compassionate care illustrates that when we're looking at compassionate care, we should not now be applying these other limitations to it regarding positivity rates and whatnot. We should recognize it as the exception that has been for the last 6 months that says that this kind of visitation is appropriate regardless of what else may be happening with the facility as a whole or as the community as a whole. Next slide, please. I also want to mention the issue of outdoor visits and note that in the same way that compassionate care shouldn't be limited to some of these other limitations, compassionate care and some of these other visits like the Ombudsman program should not be subject to the quote unquote preference for outdoor visitation. Part of this is how it's laid out in the guidance. It's a separate discussion. And then even if it somehow were considered part of the same discussion, I think you can make a very good argument that compassion care is not practicable outdoor, and Ombudsman program visits are not practicable outdoor either, in part because for Ombudsman staff to do their job, they need to be inside the facility. They have to be able to observe, and that obviously is impossible if you're sitting at a table in a parking lot outside the facility. Next slide, please. And for similar reasons, the discussions about the length of visits and the number of visitors, as Jocelyn mentioned, those limitations are discussed in the guidance as relevant to the in-person visitation, whether inside the facility or outside. They do appear to be separate from the discussions of compassion care, Ombudsman program, and the access rights of other health professionals, as Jocelyn pointed out. Next slide, please. Make a quick note regarding advocacy assistance. The guidance discusses Ombudsman visits, and it also discusses visits by the protection and advocacy programs. They aren't equivalent actually and described in the guidance. I don't think that's justified, but I just note that the discrepancy here, that the Ombudsman visits in the guidance can be limited due to infection control concerns and or transmission of COVID, whereas in the discussion of the protection and advocacy programs, for whatever reason, there's no such limitations. Next slide, please. And also, similarly, note the discrepancy here when you're talking about the other professionals. There aren't any kind of broad exceptions applicable to the hospice staff or other necessary healthcare professionals. There, the access is required as long as essentially there's no particular problem with that particular professional due to an exposure to COVID or symptoms of COVID. Next slide, please. These last two slides, I think, the last two slides that I'm going to discuss, I think are where the action may be. I can see disputes here. This discussion of testing being encouraged. So the first bullet point, I think, is less problematic, because if facilities want to do testing, they could do so. I think it'd be important to have this rapid result testing so people didn't have to wait multiple days. But there, obviously the relevant point is that the facility, it's assumed that the facility has taken that on, that the facility is doing the testing, and presumably the facility is bearing the cost. Not so much for the second bullet, which talks about facilities encouraging visitors to be tested on their own a couple days ahead of time, and if with proof of negative test results. The implication there, I know the language, the word there is encourage, but you can imagine facilities essentially requiring it. And if they're requiring a proof of negative test results, it suggests that people who weren't able to do that would be denied access. And I can see that. I recognize the cost, and I also recognized the what appears to be a conflict with the guidance, which says that the visits are required. So, not to give any facilities any particular suggestions or encouragement in that direction, but I can imagine these sort of issues arising as implementation goes forward. Next slide, please. And then finally, the core issue of what if people don't comply? And that's always a central problem here. What if they just say no? We talk about the state issue and the discrepancy between state policy and federal policy. Sometimes maybe the states have had policies that have allowed visitation that CMS doesn't recognize. Sometimes the state's policy may slide in the other direction, and that is the issue there. You can get into some law school type of discussions about primacy of federal law, and what's the floor, and what's the ability of a state to go beyond the floor, and whether you're talking about, I'm not gonna belabor that. And I think it's hard to, on a webinar like this, to just say right out that there's some clear way of making those distinctions. It's going to depend on how it plays out. I would suggest that when people think about this, that the cleanest way to think about it is to focus on residents' rights. That residents have rights to accept visitors, and remember, the right is the residents, not the family members or not anybody else's. It's the right by the resident to have access to people. And if you think of that as a federal right that's binding on states and on facilities, that may help in thinking about whether of how to reconcile the CMS guidance and any state policy, because those rights should control the situation. There's these regulatory rights. They've been waived to a certain extent, but not completely. And CMS notes in this guidance that under particular visitation regulations in 483.10, facilities are obligated to recognize those rights. And then finally, the issue of non-compliance by facilities. And I'd be interested in people's experience. My general understanding when this came out, based on the trade press, is that there was not a huge pushback by the provider organizations. I don't think so. I didn't see American Healthcare Association or Leading Age show up in the trade publications the next day saying this is an outrage. It's going to put people at risk. I didn't see that, and I think, in fact, a lot of providers had been on board. Some of their positions had been somewhat consistent with the consumer advocacy position, saying that the limitation of visitation was just too demoralizing, that it had gone on for too long, and residents were suffering. That being said, over the last couple of days, I've talked to a couple of people with ties to facilities, and they've suggested to me that that some of these individual facilities see these rights as incredibly problematic, and may take the position that it's better for them to be in non-compliance than to honor these rights. Again, I'm not trying to give anybody any suggestions on the provider side, but just to note this. I'd be interested in people's experience here. Again, I've seen both sides of it. I've seen some general support by provider organizations. At least I haven't seen this huge flare-up, but I'd be interested in, that doesn't, they're not binding to those thousands of facilities around the country, and we'll be interested to see how all those facilities in all the states respond as these this guidance continues to be implemented. And that then will be a segue for Robin to pick up about what we do as advocates on the individual level or at the state level to make sure that these rights are effective and as consequential as they can be.
Thank you, Eric. So as Eric noted, I want to present some advocacy tips around visitation at both the facility level and at the state level. Next slide, please. So the issue becomes what can you do if you're a family member and you're denied visitation? So if we could go to the next slide. So as Eric noted, actually the more appropriate way to phrase this is as a situation being the resident is being denied access to visitors as required under residents' rights. But the way we are hearing it, because it's family members who are coming to us and expressing great concern. I've phrased it in terms of the you being the family member. But there are three approaches I think that you can consider taking, and these sort of all go back to what Jocelyn had laid out for you in terms of allowable and required visitation. So the first approach I'm suggesting is what I'm calling the only with reasonable cause argument. And just so you know, I'm making up the names of these arguments myself. But in this approach, I think you should ask why your visit is being denied. And remember that facilities can only restrict visits if there's a reasonable clinical or safety cause. So ask why the visit's being denied, and then compare the reason that you've given or that you're given with the permissible reasons, which you see listed again on this slide. And if it's not one of those reasons, I think you could argue that the facility cannot deny you access because it doesn't have an adequate reason related to clinical necessity or resident safety. Next slide, please. So some of you may be familiar with that old saying, trust but verify. So let's say that the reason you're given is a permissible reason, and that you're being told that there are cases of COVID and or that the county positivity rate is too high. Well, in those cases, I think it's definitely worth verifying those reasons. Next slide. So in terms of cases, you will have heard on our previous webinar, or may already know, that there is a federal rule that requires the facility to report cases to family members or resident representatives. So it says, and this is the actual regulation here on the slide, it says that facilities must report, and I'm going to simplify a great deal here, but that they must report any new confirmed cases, and that's resident or staff cases, by 5 p.m. the next day after the case has been confirmed. And they also must provide cumulative data, so that means the sum total of the number of cases, at least weekly. So you're going to know if you're a family member or a resident representative, you're going to know if there have been any new cases in the last 14 days. Next slide. So in terms of county positivity rate, which keeps coming up, facilities have been directed to use the positivity rate data for their county that's posted on the CMS website. So on this slide, I've given you the CMS website link and then their directions for how to get to the county positivity data page. Next slide, please. So here's what the data page actually looks like. And so if the county where the nursing home is located is green or yellow, that means the positivity rate is low or medium, and general visitation cannot be restricted. So trust but verify. Next slide. So the next approach, a second approach, if you're denied visitation, is what I'm calling the it's required argument. As Jocelyn noted, CMS has very clearly stated in the guidance, and I've written it out again here, this is the exact wording, that if a facility has had no COVID-19 cases in the last 14 days and its county positivity rate is low or medium, a nursing home must facilitate in-person visitation. So use your knowledge of cases in the facility. You can track the county positivity rate the way I've just explained. And so then if the facility has had no COVID cases in the last 14 days and its county positivity rate is low or medium, then you should literally point to this statement in the guidance. So take, have it highlighted and present that either, virtually or just over the phone to the facility, and insist on being allowed to visit. This statement, unlike many in the guidance, is clear and unambiguous. So it's one of the very, very few parts of the guidance that actually says must. So use it. Next slide. So I'm calling this third approach the eligibility argument. So according to the guidance, some residents may now qualify for one of two kinds of visits: compassionate care visits, particularly now that additional examples have been added in the guidance about a resident experiencing severe decline and or distress, or what we're often referring to now as disability-related in-person support visits that Jocelyn discussed, now that those have been included in the guidance. So for both types of visits, what you would want to do is to make the strongest case you can for how your loved one's situation, condition, and or needs makes them eligible for one of those types of visits. Next slide, please. So, of course, the big question is, what do you do if, despite your best efforts, you're not permitted to visit when you think you should be? So sadly, we don't have a magic wand, nor is there a silver bullet that will guarantee success. I wish I could say otherwise, but there are certainly a number of steps that you can take. Next slide, please. So we've listed out a number of strategies that an individual family member could take, or even a family council could take. And this slide outlines those strategies, and each of these strategies is explained and discussed in detail in two fact sheets that we have, and I've listed those at the bottom with links. Family advocacy for nursing home residents during COVID-19, and one about family council advocacy during COVID-19. So I would really urge you to check out those resources for more information. Next slide. I do want to mention one strategy that I haven't covered, and actually it does need to be added to our fact sheets and our information now that the guidance has been revised. And this is the situation where if your loved one is being denied what's called full and equal access to care under federal disability rights laws, such as the Americans with Disabilities Act, you should consider filing a complaint with the U.S. Department of Health and Human Services Office of Civil Rights. And you'll remember the example that Jocelyn gave about a resident with dementia. One could definitely file a complaint with the Office of Civil Rights. Again, no guarantee about the outcome, but it would certainly be worth pursuing, saying that your loved one, because you're not able to come in and assist, for example, with communication, your loved one is not getting full and equal access to care. So it's certainly another tool to add to your advocacy toolbox. Next slide, please. So I want to say just a few words about state level advocacy. So right now, states are all over the place with visitation guidance. Some states are saying that their own guidance and directives are more restrictive than what CMS has, and they're going to keep theirs and not adopt the CMS guidance. Other states have said that they are, in fact, going to direct facilities to follow the CMS guidance, or they've kind of incorporated the guidance into their guidance. There are some states that are saying, frankly, they don't know what to do because their guidance is more restrictive, and so they're seeking clarification from CMS about this issue that Eric raised about state or federal guidance, which one takes precedence, which one is primary. And then we have a very small number of states that are coming up with rules that I would describe kind of as a hybrid between their own state directives and some of the CMS guidance. So as I said, it's all over the place. I think it will, I imagine, evolve, particularly if we do actually get clear clarification from CMS. But the goal of your state level advocacy is obviously to ease the current restrictions on visitation. So what you end up advocating for is going to depend on where your state is with visitation. So for some of you, you may be advocating for the CMS guidance to be implemented and not your state directives, while for others, you know, you might be trying to preserve kind of what you think is actually better than the CMS guidance in your state directives. So again, it's going to vary. So just some general tips, and you know, as always, I think we should look to what other states are doing. Many of you have sent us your guidance once it's been developed, and that means that we have a number of examples from different states that we certainly can share with you so that you can see you know, different approaches to visitation guidance. We also, Consumer Voice, along with a number of other advocacy groups and individual advocates, developed recommendations that we submitted to CMS. So those are posted on our website and can be a source of information. So reaching out to other advocates in different states can be incredibly valuable and helpful. But I would urge you not just to reach out about the substance of what the guidance says, but also to learn how other states are achieving this, are making this happen. We have really seen, I have to say, some extraordinary advocacy on this issue around the country. So in terms of approaches and tactics, we've had families that have been coming together on Facebook, hundreds and hundreds of families, and forming groups. There have been petitions, there have been rallies, there have been protests actually in front of nursing homes, or as you can see on this particular slide, in front of the office of a legislator. There have been social media campaigns, letters to policymakers, and as I'm sure you all know, very powerful and moving media stories. Next slide, please. So I want to give a huge shout out to all of you who've been pushing for lifting the restrictions. Thank you. You have really made a difference. So I want you all to take a moment to acknowledge and celebrate your successes. Next slide, please. Okay, now take a very deep breath and gear up for another round, because our work, unfortunately, is far from done. We need to keep up our advocacy so we can continue to move forward toward full restoration of resident visitation rights. And we need to hang tough and stay determined, because with growing concern about the flu season and a second wave of COVID, we're really worrying that there will be a tremendous push to lock everything down again. So we've seen the harm that complete lockdown, however well-intentioned, has done to residents. So we must not let these policies continue to literally protect residents to death. So with that, I'm going to turn it back over to Lori.
Thank you, Robin, Jocelyn, and Eric, for your presentations today. Very informative and helpful, and have addressed a number of the questions that have come in. I just want to remind folks that on the Consumer Voice website, we've got a lot of resources about COVID, about family advocacy that you can access, and the link is the first one that you see on your screen. We've launched a new webpage specifically related to visitation, which will include a lot of the information that you heard about today. It'll link to the CMS memo. We'll be putting the slides and the recording up there today. And it also includes a list of things for you to look for and to look at when you are going back in for visitation. We've also launched what we're calling a re-entry survey for families that we're asking you to fill out as you've gone back in, to let us know what you're seeing as you go back in. What are the conditions? What are you seeing with respect to your loved ones? So we're trying to get a sense of what people are observing as they go back in, and what the conditions are, both good and not so good. So we will encourage you to take the survey, and as always, we never share any information without your specific consent on those. And then also to continue to stay updated on information that we produce at the Consumer Voice and share, we would encourage you to either join as a member or join our Action Network to stay, again, up to date. So next slide, please. So we have a few minutes left where we'll take a few questions. We're obviously not going to be able to get through all of them. We have more than 100, but we'll be trying to get through as many as we can in just the next couple of minutes. A couple things, as Sam, maybe you can cue some of them up for us. A couple issues that I just wanted to address as we're queuing up. One is to just remind folks that these guidelines that we've talked about today from CMS apply to nursing homes. We get questions about what applies to assisted living. And CMS right now regulates and oversees nursing homes. Assisted living fall under the purview of state regulations and state guidance. So these rules do not apply to assisted living, or the guidance doesn't. But watch for your state guidance and information to assess what applies to assisted living, and you can contact your state regulatory agency, your Department of Health, or even your Ombudsman program for more information on how to get that information about assisted living. Another thing is a number of questions came up about Ombudsman access, and you did hear from the presenters that some of these rules do address Ombudsman access. But if you are a local or volunteer Ombudsman on the call today, stay connected with and take guidance from your state ombudsman on what you are supposed to be doing with respect to going back into facilities and how your visitation will resume. Your state ombudsman will be providing that guidance and information to you. So take direction from them on your role there. And then the last thing I wanted to say is there are a lot of questions that have been coming up, and as you heard from the speakers today, there are a number of things that we're still trying to clarify in terms of particularly the relationship between state guidance and federal guidance and what applies and how that works. And so we are going through your questions, and we'll continue to do that, and we are continuing to do outreach to CMS to ask them to provide some clarity on what they mean with respect to the guidance that they've issued and how it applies and what the requirements are. And we'll continue to report back to you as often as we can related to that. So with respect to that, Sam, can you queue up a question for us?
Sure. There was a lot of questions about facilities requiring, can facilities require that visitors be tested?
Anyone want to handle testing of visitors?
I can. It's Jocelyn. If no one else does, I'm looking at the guidance, and it specifically says that the testing is not required. I mean, the guidance says, while not required, we encourage facilities in medium or high positivity counties to test visitors. And it also says, and this is, I think, a little bit disconcerting for people, that facilities may also encourage visitors to be tested on their own prior to coming into the facility with proof of negative test results and the date of test. So it doesn't say that it's required, but it does say that facilities can encourage this. So I think that that's going to be another issue that's really left up to the interpretation of the facility. CMS is not requiring it, but I do think it's one of these gray areas where facilities might say, oh no, we can require this or we should require this. I would encourage you, if you come up against this when you're trying to visit, we have links to the guidance on our webpage. I put them at the beginning of the webinar slides. I'd print out the guidance and I would highlight where it says this is not required. And I would try to use that as your argument, because I do think there will be instances where facilities try to sort of push the envelope on this.
Thanks, Jocelyn. Eric?
Yeah, I would look at the part that talks about required visitation and the only factors that can be applied to restrict a resident's right. I don't want to turn this into a big argument back and forth. You can, in maybe the worst case situation, the facility would claim that this is another relevant factor, but like Jocelyn said, I think that we want to push back. That the seat of the pants argument is that it's not really a great right to visit if a family member has to drop $50 every time they do it, whatever the number is, in order to get a test. When CMS has said that the things to look at are positivity rates in the community, an outbreak in the facility, and we already have testing standards, right? We already have testing standards that don't require testing of visitors. So those are the things that I would push on, because you don't want this to turn into something that really makes visitation essentially prohibitive for residents and their family members.
Thanks, Eric. Another question, Sam?
Sure. There was, as regards to compassionate care visits and visitation, there was a couple of questions about who should family members contact to help facilitate these. Who in the facility should they contact to help facilitate these visits?
So this is Robin. That really is going to vary from facility to facility, but I think a very good starting place would be to contact the social worker or the social services personnel.
Thanks, Robin. Sam?
And I guess along that line, is there any language on the capping the amount of visits, compassionate visits? Is there, or the frequency of them?
It's Jocelyn. There isn't language that does that one way or the other in the guidance, and so it's very unclear. I would argue, if you're trying to use compassionate care to visit, and again, I think that we can argue now that it is much more expansive, argue that all of this guidance is person-centered, and they make that statement that, you know, visitation should be person-centered, and in fact that's why they didn't include some kind of essential caregiver category. So I think that you can make the argument that in situations, for instance, where you come in because your relative has lost weight and because they're not eating, you know, a facility might say, okay, you have one compassionate care visit, but that is obviously not really what the intention of this guidance is, because these visits are to help meet the residents' needs. And so I think you can make an argument that you should be able to come in repeatedly to help. But again, that's an argument that you are likely gonna, in some cases, some facilities might be quite amenable, but in some cases you're gonna have to push that. But I would really emphasize that visitation is now person-centered, and that you know, in these compassionate care situations, your loved one needs multiple visits from you to help them with their emotional or physical needs.
I'm going to reiterate something I said during the presentation. I think that compassionate care, by and large, should be kept separate from the standards for the quote unquote new standards for in-person or outside visitation, both because of the way it's set up in the guides and because of the fact that, again, we've had compassionate care allowed straight through from March to the present. I think it's appropriate to look at it as a separate animal as compared to the standards for broad access that apply to every resident in the facility.
Thanks, Jocelyn, and thanks, Eric, for your answers to those questions. Well, we're at the top of the hour today. A reminder that the recording and slides will be emailed out to all of you and posted on the Consumer Voice website. I'd like to thank Eric, Jocelyn, and Robin for your presentations today, and Sam and Libby for helping out on the back end. And please, if you have been in to visit your loved one, fill out the survey that we have listed on the new Visitation website, and you can access it on the COVID websites on our webpage also. And we'll continue to update the information on those pages as we continue to receive it. So thanks so much for your time this afternoon, and have a good rest of the day. Take care. Bye-bye.